with that is that you have patients who are not really fit for pregnancy because of societal pressure. They're going ahead and trying to get pregnant. So to curb this, shall I continue? Am I audible? See, at the end of the day, the whole aim of the treatment is to get the patient pregnant, but at the same time, we have to be sure that the treatment is safe for the patient. Tomorrow, if we are bringing a child into this world, the couple should be fit to take care of the child. So with that whole point in view, the government of India has come up with the fixed age limit for both males and females. So as far as the men are concerned, the upper limit is 55 years. As far as the females are concerned, the upper limit is 50 years. So any couple where the wife is more than 50 and the husband is more than 55 cannot seek assisted reproductive treatment. So that's the limit which is set up by the government because of the logic which I provided you before. The infertility as such, the fertility prospect.
No, but then the concern is there is a growing infertility population in our country. It's already 14 or 20% of the population.
So I'm coming to that.
Yeah.
So we have the age limit now, which is 50 and 55. So someone asked, how do we get these patients pregnant, right? So there is a remarkable decrease in the fertility rate after 35 years as far as the female is concerned, mainly after 37 years of age. As far as the men are concerned, the male partner, age does not impact as much. Okay, so that's why the upper limit is about 55. If a lady is using her own eggs, the success rate of the treatment depends upon the age of the lady and how much is her ovarian reserve. That is, how many eggs does she have. So suppose even if she is around 42, 43, but if she has a good number of eggs, we can try to use her own eggs. But as the age is increasing, there's an increased risk of miscarriage, of having children with abnormalities like Down syndrome. So if we are using an elderly lady's eggs, we need to do a biopsy to determine if these embryos are genetically normal before transferring them. So to try and improve the success rate in this population, we can use their eggs, but at the same time, we should subject them to genetic analysis before transferring them. Now we have a lot of ladies where they have very less eggs. So earlier the only option available for such patients used to be just go for a donor egg option. Why are you even trying with your own eggs? But there are a lot of women who have an inherent need. They want to try, they want to get pregnant with their own genetic material. They don't want to use donor egg that easily. So in that case, we are coming out with ovarian PRP. We have been doing ovarian rejuvenation for our patients with very good results. And we also do double stimulation pull-up cycles in order to increase the success rate in these patients. So there is a lot of new innovations which are happening in this facilities, in this faculty, especially in order to help this, the couples with advanced age. Because most of the patients which we see in our OPD right now are the ones who are around between the age bracket of about 37 to 45 years. Where most of the clinics outside are actually giving up on them and telling them go for a donor gamete. We are trying to help them with their own eggs as far as we can. So that's the crux of it. I hope I've answered your question.
Yeah, but the concern still is with large number of parents planning late pregnancy or parenthood. How can, there be a restriction? You're trying to say that after 55 they're not allowed to go for IVF?
If the male partner is 55 and if the female partner is 50.
Yeah, the age bracket that you gave. Yeah, so that means they're not allowed to go for...
They are not allowed. We are not allowed to offer them treatment. So first, coming to this whole point, first and foremost is education of the population, and that's where the media helps us. And we are trying to do our bit with your help and otherwise through various platforms where we are trying to educate the population that there is a biological clock. You need to be aware that career is important, but if somewhere you want to have a family in the future, keep that in mind, get yourself tested, see how much time you have, what is your prospect. If career is really going up and you don't have time for bearing a baby right now, you can go for fertility preservation. You can get your eggs frozen. We have that option available. It's an excellent option for career-driven females.
No, but in that case, can parenthood be given after 55?
No.
Okay. All right. So
it's not safe for the women to get pregnant after 50.
Okay. The other important factor is that fertility clinics have an exorbitant price, which is not affordable to a particular segment of society. So how do you address that? Because there is no insurance on that.
Yeah.
So organizations like yours should actually pressurize for those kind of...
So I think there has been an initiative by the central government as well to try and encourage the insurance companies to try and include fertility treatments, and that's one thing which needs to be done. As far as we do,
that was only for pregnancy and not for fertility.
No, they are encouraging them. There was a recent article where they did try to tell them that it should be included, especially since we have surrogacy insurance and all those things. So there has been the government is trying to ask the insurance companies, but that's a different topic. As far as we are concerned, what we are doing in order to make our treatment as accessible to our patients. See, this whole point about fertility treatment is very expensive. Nowadays, we understand a bit more about it. Initially, when it was more exotic and you had a couple of people doing it, very few patients had access. Yes, I do agree it was expensive. But now most of the drugs are in-house, they are manufactured in India, the rates have come down. We are trying to come up with treatment options where the treatment is as affordable as possible. Okay, so we see what the patient profile is, we do and educate the patients about the various options, and I would say the treatments now are fairly affordable, somewhere about between 1.5 to 3. But there will be a lot of time patients will come and tell us, you told us that the package is so less and ours is coming up to this much, and so and so got treatment done so easily, but ours is exceeding that point. So what you have to understand is infertility treatment is personalized. One shoe fit does not fit all. It's based on what is wrong with the patient that we try to treat. You don't have a standard prescription given to everyone. So based on what is wrong with the patient, we try to solve it. And that's where the difference in the cost can come. But if you have to look at the cost, I would say it's fairly affordable. What I have seen in the last 6-7 years, only the cost is almost half of that right now.
Is there any basic and common side effects for patient?
Sorry?
Is there any basic side effects, symptoms or something which a patient should be aware of, but that is also treatable?
Side effects of infertility treatment? See, treatment again, like I said, as we are understanding more of it, the treatment is very safe. Initially, there used to be a risk of hyperstimulation. You used to hear patients falling ill with ovarian hyperstimulation syndrome. Wards where the infertility clinics were, there used to be 2-3 patients admitted with all this. Now with the newer protocols, these are almost unheard of complications. We have something called as zero OHSS clinics. So complications as such are very rare. Okay, so it's a very safe treatment. The medicines which we use, they are very short acting. So there will be some patients who will be concerned about, can we develop cancer with this in the future? No, it does not increase your risk of cancer. So that is something which you need to understand. And trust me, we are very much concerned about our patients' health. So if before starting treatment for anyone, we do make sure that the patient is thoroughly evaluated to be sure that there is no coexisting comorbidity which increases their risk. If a patient comes to me with hypertension, diabetes, obviously any procedure you do, the risk is increased. So those things are evaluated and taken care of. But fertility treatment as such is very safe. Anything else?
Now, what is the exact cause for this growing infertility? Of course, polycystic syndrome is one, ovary syndrome is one, and the pubertal factors. But what are the real causes for that? Increasing PCO and...
I would say polycystic ovaries is the most, PCOD as they call it, is the most glamorized. Everyone thinks they have it. Okay, it's mainly because of lifestyle changes. People nowadays are not that active. We have a very sedentary lifestyle. Most of us are involved in desk jobs. As a result, people tend to be heavier. Ladies are, the body mass index is more. And because of that, PCOD is a form of lifestyle disorder. So it's a manifestation of that. So if you have an active lifestyle, there's less likelihood of developing all these lifestyle associated risks. Excuse me. But at the same time, because of various environmental factors also, it's not just PCOD. We are also seeing rising trends of diminished ovarian reserve. Patients are achieving menopause much more earlier. We have patients with very less reserve coming to us who are just in their 25, 30s. Kind of ovaries which you see for a 45-year-old lady is what we are observing in 30-year-old girls. So, a lot, because of PCOD being so popular, people think that if they have irregular periods and if they are a bit chubby, they have PCOD. But you need to understand it can be the other side where you don't have any eggs and you're going towards menopause. So if anyone has these complaints, rather than self-diagnosis that I must be having PCOD, it's better they visit the fertility expert, get themselves diagnosed, and accordingly act on it.
Post-delivery, what is the time period the parent and the kid should be monitored?
Sorry?
Post-delivery, the parent and kids, how long should they monitor?
I didn't get you, sorry.
Okay.
Post-delivery,
Yeah, post-delivery, the mom and kids, is there any set of period, like 5 years or 10 years, it needs to be monitored clinically or
monitored for what?
their treatment? It's about their health condition.
Sorry, I'm not getting the question.
Yes, you're asking is it because of IVF?
Yes. After in this IVF, there was a time where they should be monitored. Like, is there anything like they should come every 2 months or 5 months?
It's a routine evaluation. But you're asking about fertility conceived patients and their kids. It's a routine evaluation. So it's for the treating gynecologist and pediatrician to see whether they need any extra consultations or extra, investigations. As such, infertility treatment does not increase your risk of it. But yes, fertility treatment, usually the first 3 months of pregnancy is supported by medicines. So that is a bit intensive care. After that, it's like any other precious pregnancy. Anything else? One thing I just wanted to mention, one more thing, that besides PCOD and everything, we are seeing a lot of patients where they conceive very easily the first time. The second baby, when they are planning, that's when they are having difficulty. So secondary infertility is something which is on the rise. And a lot of patients who conceive easily the first time are needing our help to have their second child. So that's another place where we are seeing that a lot of population is coming to us with secondary infertility. Is that all? Thank you so much.